This is a second of two videos on operative vaginal delivery. In this video, we'll talk about key prerequisites for operative vaginal delivery. We'll talk about outlet forceps, vacuum extraction, forceps for the aftercoming head, which occurs obviously with breech deliveries, as well as complications. To review, there are key prerequisites for operative vaginal delivery. The cervix should be fully dilated and retracted. The membrane should be ruptured. There should be engagement of the fetal head. Very importantly, the position of the fetal head has to be determined, and one should have some estimate of the fetal weight as well as adequate anesthesia. As shown here, this is a position of LOT, and here you can see the sutures as well as the anterior and posterior fontanelle. At times, you will have some degree of asynclitism. As shown here, there's anterior asynclitism. When this occurs in the LOA or ROA position, usually with outlet forceps or low forceps, one can correct minor degrees of asynclitism with the so-called traction devices used for these types of forceps deliveries. It's important to recognize what the various planes of the pelvis are. Certainly the high plane or inlet is important because if the fetus's head has not traversed this, certainly the likelihood of being able to do any type of delivery is certainly reduced. Midplane also is important at roughly the level of the spines or actually above, but again, applying forceps in this position is certainly discouraged. At the level of the spines are the so-called low or mid, and finally you have the low, which would encompass both outlet as well as low forceps. Outlet forceps requirements are that the scalp be visible at the introitus without separating the labia. The fetal skull has to reach the pelvic floor. The fetal head is at or on the perineum, and the fetal head is in an OA, OP, or ROA or LOA position, and rotation does not exceed 45 degrees. To be classified as a low forceps, the leading point of the fetal skull is at a station plus 2 centimeters or more, but not on the pelvic floor. Without rotation, the rotation still would be 45 degrees, but from an ROA or LOA to OA, or an ROP to LOP to an OP, and on occasion you have rotations that will exceed 45 degrees with a low forceps delivery. And this just shows the fetal head in position at the various planes of the pelvis. And again, if you look at the low, mid, as well as low, and low will again encompass both what we call low forceps and outlet forceps, you can see that as the head descends, there is the rotation that occurs, such that in most instances with both low and outlet forceps, one has LOA or ROA or a full OA or OP position as opposed to the transverse positions that one can see. And this all has some importance in terms of what sort of vector or traction that one applies based on the position in the fetal pelvis. And if you look at positions 3 and 4, here again you can see that although the head is much further down, there is some difference in where you should use your traction and in what direction you should use your traction according to these positions. So let's look at how we would actually apply a forceps. Here one is doing what is known as ghosting, where you line up the blades in the position that you think you will utilize them. In general, the right blade is on top because this facilitates the ability to articulate the blades once the forceps are applied. And applying the left blade initially, the handle is towards the right groin. You insert it in front of the ear with pressure towards the fetal occiput. And the only time that you might not apply this blade initially is if you have, for example, an ROA position. And here you would probably apply your left blade so that you don't have further rotation when you apply the blade as you usually do, as shown here. From the standpoint of, again, applying the next blade, here again, the right forceps blade is inserted. The handle is towards the left groin. You apply pressure against the occiput to ease its application. Once it is applied, you then drop the handles in order to articulate or lock the blades. In addition, this flexes the head and facilitates subsequent extraction. Once the blades have been locked together, it's critical to check for placement. The posterior fontanelle should be midway between the sides of the blades and about 1 finger breadth above the plane of the shank. The sagittal suture should be perpendicular to the shank, and the fenestration should be tightly applied to the side of the head such that you can barely insert, let's say, a fingertip between the blade and the head. Traction, as shown here with the Sex-Torque-Peugeot maneuver, means that with the left hand as shown here, you have some downward pull, and with the right hand, you have pull that's outward in the horizontal plane, such that the overall vector is downward, say at a roughly 30-degree angle. This can be facilitated with the use of a traction handle device, such as the build device shown here, where one needs only to pull on the device to get the appropriate vector or traction. Once you've completed the delivery, or you're about to do the delivery, using, let's say, the Ritkin maneuver, the blades are then removed in the opposite order that they were put on. The right comes off before the left blade. Occasionally, as noted, you may have to rotate the fetus from a 45-degree angle to an OA position. Note that these forceps are designed such that the blades are above the plane of the shanks, so that if you just twisted the handles, this would carve an arc that would be such that you would have difficulty doing the rotation, plus probably increase the risk of a vaginal laceration. Such that in order to properly rotate even at a 45-degree angle to the appropriate area of OA, one has to use the toe of the blades as sort of the fulcrum, and again rotate the handles in a relatively large arc. And this is shown here where LA position of the fetal head is rotated to an OA, again rotating the handles around in a somewhat wide arc. Vacuum extraction, again, has the same sort of principles and prerequisites. Here you see the cup, you see the basically the piston device which produces the vacuum. Proper application means to place this on what is known the flexion point. And this is a point that, again, by placing it here and is lined up with the fetal chin, one, when doing the traction, does not end up with excessive extension of the head or flexion of the head. And the position, when you look at the top of the skull, would be 2 or 3 finger breadths below the anterior fontanelle, with the one edge on the posterior fontanelle towards the midline, as demonstrated here. Again, you follow the same sort of vectors that you would in doing an outlet forceps, depending on the level of the fetal head in the pelvis. As you apply, you can have fingers against the fetal scalp to detect any possibility of pop-offs. In general, one does not utilize this on fetuses that are less than 34 weeks. You tend to allow only 3 pop-offs, but again, this is not fixed in stone, in that obviously if you have a scalp that has a lot of hair and the pop-offs occur easily, obviously more pulls would be okay. Duration of the actual operation, that is over 5 or 10 minutes, is related to an increased risk of cephalohematoma. There appears to be no difference relative to whether you reduce the pressure in the device in between the pulls. And again, as you complete the delivery, you can use the Ritkin maneuver before you remove the actual vacuum device. Here we demonstrate how to do a forceps delivery with an aftercoming head. Note that this particular forceps, the Piper forceps, has a perineal curve in addition to this cephalic curve in order to allow the forceps to be applied below the fetus. As shown here, the handle of the blade is dropped about 45 degrees downward and is in the midplane. And here we see the left handle or left forceps going over the ear of the fetus. And in this diagram, we see the right forceps, again, about 45 degrees below the fetus, with the blade being applied over the fetal ear, with an assistant holding the fetus either by hand, or one can use a POW as sort of a way of holding the baby. Once the blades are articulated, you can either have the fetus lie on the shanks of the blades holding the legs as shown here, or again can use like a towel as a sling with the assistant holding the baby. Initially you pull downward until the occiput appears, and then you uh, move the blades towards the maternal head to deliver the rest of the head. And this shows a proper application with the baby about ready to be delivered using this particular device. With any type of delivery of this sort, there are complications, and with any operation involving a mother, there can be both maternal as well as fetal issues. From the standpoint of maternal issues, third and fourth degree perineal tears are probably the most significant. And this is data from over 1 million singleton prima gravida term births in England. And you can see that the rate of perineal tears, third or fourth degrees, was higher with forceps compared to vacuum, but episiotomy did provide some protection against major tears. In this particular data set, which again involved doing interviews of individuals who had undergone deliveries during the year after their delivery, you can see that the frequency of defecatory symptoms was much higher in those who had undergone forceps deliveries than vacuum deliveries, and even women who'd had a vaginal delivery with a medial lateral episiotomy or second degree tear tend to have a far less frequency of defecatory symptomatology. Relative to fetal injuries, this is data from 83,000 singleton births of prima gravida patients at term in California between 1992 and 1994. You can see that the use of vacuum as well as C-section after vacuum and or forceps all again increase the rate, but the combination of forceps followed by vacuum again increases rate of both intracranial hemorrhage and other injuries including facial nerve, brachial plexus palsy, seizure disorder, CNS depression, and need for mechanical ventilation. With a vacuum also there is about a 2 to 4% risk of subgaleal hematoma, and there's also an increased risk of neonatal jaundice related to the occurrence of cephalohematoma. However, if you look at long-term sequelae comparing normal vaginal deliveries versus vacuum or forceps, there's not significant differences among all of them, with the exception of the perineal tears and defecatory symptomatology. So the fetuses, again, tend to do well overall. So in summary, operative vaginal delivery is still an important part of obstetrical care. Certainly it can expedite delivery when needed and avoid cesarean delivery. Certainly practitioners must know the risks and benefits and convey them to the patient. In addition to a knowledge base, practitioners must also develop and maintain the skills to safely use these modalities.